I think when it comes to infantile colic, there are 2 or 3 key things. One is how distressed the child looks. Sometimes, when it comes to infantile colic, the child can actually look quite distressed. The crying can be quite prolonged, and the crying can be quite loud. Unfortunately, none of these actually correlate to whether there's a significant underlying pathology. That means an organic pathology for apparent pain and discomfort. But parental perception is, as long as my child is crying, as long as my child looks distressed, something serious must be present. So this is one probably good example whereby the parents will perceive a symptom as being serious, but actually the symptom that the child is experiencing does not indicate underlying disease. So again, infant colic is fairly common. Unlike regurgitation, it's probably a bit more distressing to parents because parents will associate crying with some kind of discomfort in the infant. So whenever the infant has colic, usually they would appear to be in pain. They might scrunch up their legs, kick, be a bit uncomfortable. So that in itself is very distressing. The key, of course, is to assess the child to make sure there's nothing untoward. So clinical exam to make sure the child's well, ensure that the child is otherwise feeding okay, putting on weight okay, know what I call red flag symptoms to suggest that the child might have an allergy or food allergy, or whether the child has blood in the stools or any other abnormal symptoms. If that was so if this child has regular normal infant colic, then the key is again to reassure parents, or the mum particularly, that there's nothing wrong with the child and that it would be something the child would slowly grow out of over the next few months. The key, of course, is to see how to decrease some of the maternal anxiety and to explain to them that sometimes maternal-child interactions might make the symptoms appear worse. So the more anxious the caregiver is about the colic, sometimes the infant might sense that anxiety and that might make it a little bit worse. There are some things that can help, even though I think there's no good data to suggest that one would be better than the other. So sometimes having the infant in a room with low lighting, having some soothing music in the background, sometimes the droning of a washing machine, or sounds that would emulate waves, like swooshing of the sound of what the baby would hear in the womb or the blood vessels, might actually sometimes help. The other thing which does help is actually personal time for the main caregiver, i.e. mum. And I call that baby free time. I think it's important that if the mum is a main caregiver and doing all the breastfeeding or the care for the child, that at least once a day for an hour or so, that somebody else takes care of the infant so that she can have some personal time and baby free time. I suspect that, for example, for regurgitation, all infants would regurgitate. With regards to colic, I'm almost certain all infants also would be crying. But what percentage will actually present to their primary physician because of crying sometimes depends, I think, on maternal or parental perception of that problem. And for those parents who are more comfortable with the crying, they may not actually bring their kid to see a physician. So that's, again, in my practice, because it's a very specific GI clinic, I probably would see the more severe spectrum. I would say roughly maybe 10 or 20% of the infants I see was specifically for difficult colic. Maybe half of them would be for feeding and reflux type issues, and then the rest of them would be for things like constipation. It's just specific to problems in young children and infants. We don't have good data locally as to what that prevalence is in the community. Yeah. So that is, again, probably multifactorial. It's a combination of, again, a developmental process whereby the infant has a sense of intestinal movement. Sometimes they are more sensitized to that movement. Sometimes there's a bit of gas trapping. So they feel that as distension of the intestines and some amount of discomfort. So it's a combination of what we call physiological and developmental effects. And sometimes we notice that infants who are able to regulate themselves better tend to settle faster from that discomfort and crying. Infants who take a longer time to settle would be the ones who end up crying and fussing a little bit longer because of that. This is actually a growing area of interest. It's a growing area because there are some studies which suggest that the feeding of probiotics to infants with infantile colic might help reduce some of their symptoms compared to infants who are not fed the probiotics. What we're not sure is whether or not there's something intrinsic to these infants in terms of their own intrinsic microbiota that predisposes them to this. So this is an area which I think is still fertile for additional research. But we do know that certain strains of probiotics do help the colicky infant.